Hello, I'm Natalia.
And I'm Jeremy Heron.
Hi, and we are here to discuss our topic of delirium. We chose. We have this topic because it has a lot of information regarding delirium. Because sometimes it get confused with dementia, but it's a different form of a cognitive cognition disorder. Overview: Delirium, according to the DSM-5 diagnostic criteria, is a disturbance in attention. An example: reduced ability to direct, focus, sustain, and shift attention, and awareness, which is reduced orientation to the environment. The disturbance develops over a short period of time, usually hours to a few days, presents a change from baseline attention and awareness, and it tends to fluctuate in severity during the course of the day. And additional disturbance in cognition, an example: memory deficient, disorientation, language, visual, partial ability, or perception. Types of delirium. There are four types of delirium: substance intoxication delirium, substance withdrawal delirium, and medication induced delirium. Alcohol, which means alcohol and other sedative drugs of abuse, as well as nearly every class of street drugs. Street drugs can cause delirium in both intoxication and withdrawal. Medications also can be implicated. Delirium due to other medical conditions. Delirium can be caused by trauma to the brain, infections, epilepsy, endocrine disorders, toxicity from medications, poisons, and various other diseases affecting almost any part of the body. Delirium due to multiple etiologies. Delirium can have multiple causes in the same patient. Example: another medical condition plus substance intoxication or medication side effect. Other specified and unspecified delirium. You are to use one of these categories when you do not know the cause of a person's delirium or when it doesn't fully meet diagnostic criteria.
Delirium. Why are nurses confused? Delirium is a serious clinical syndrome that is associated with costly financial, social, and emotional ramifications for hospitalized patients aged 65 and older. This acute, short-term disturbance of consciousness that can last on average from a few hours to as long as a few months. Delirium is categorized as an onset of inattention, disorganized thinking, and altered level of consciousness. Nurses play a key role in the detection of delirium. However, the condition is widely unrecognized and mismanaged. The purpose of this study was conducted to determine the proficiency in detecting delirium-related behavior/information, as well as the nursing staff's perception of their own competency when identifying and treating symptoms of delirium. The mismanagement of delirium-related behavior may be correlated to the lack of knowledge about delirium, risk factors, and preventative measures. The scope of the study was to evaluate the nurses' years of experience, level of education, and area of practice to determine if nurses are demonstrating difficulty in the recognition/determination of delirium-related behavior. The study administered a questionnaire completed of 260 nurses, 34 of which held a BSN, 18 held an ADN, 6 an MSN, and 2 secondary diplomas in nursing. 20 of the nurses that participated in the study reported between 4 and 7 years of nursing experience. 14 reported 20 plus years in the profession, and 9 nurses reported less than 3 years in the field. The questionnaire included specific questions in relation to delirium-related behavior. Question 1. What was the nurse's level of knowledge of delirium? 22 questions relating to general information about delirium was administered. And the results were, on average, correct answers were about 15.32, about 42.55%. Only 35% scored over 75% in this section. Question 2. What were the nurse's level of knowledge of delirium's risk factors? And the results there were average of number of correct answers were 21.62. And only 10% scored higher than a 75 in this section. Question 3. Was there a correlation between nurses' years of experience, education, and practice area and their knowledge of delirium and its risk factors? Results. There was no evidence of statistical data that supported a correlation between years of experience to correct answers. Question 4. How did nurses perceive their own knowledge competency related to delirium? And the results were 1.67% described having advanced competency, very small number. 9 or 15% considered themselves to have above average competency about delirium. 33, about 55% of the data collection pool perceived themselves of average competency. 11 reported minimal competency, and about 10% said they lacked competence. Less than half of the participants scored at least 75% on both the general delirium and risk factor questions. Conclusion. There is statistical evidence that support nursing staff demonstrating a general lack of knowledge concerning delirium-related behavior. Delirium can be treated and is commonly preventable. If preventable interventions are delayed, delirium can result in continued deterioration of the patient's health, long-term care placement, and death. This article did not intend to discredit the hard work and dedications nurses demonstrate on a daily basis. The study was conducted to provide statistics to show a need for educational programs to include assessment and prevention strategies in caring for patients with delirium or those at risk for delirium-related behavior. This can provide healthcare professionals with a skill set to become more proactive in the recognition and treatment of a widely unrecognized syndrome that can improve the quality of life for others. 3 national web resources for delirium can be found at www.americangeriatrics.org, www.americandeliriumsociety.org, and www.cancer.gov about treatments, side effects, and memory of delirium. All 3 of these web-based websites can give you information on some signs and symptoms of delirium, and some of the things you can look for in a patient who may be suffering for delirium, and supports for family and clients that you may be working with. To conclude, we have a short video on delirium. That I'm going to play now, and that will conclude our presentation.
Delirium is defined as this acute or sudden change in mental state, which is different from dementia because remember that dementia usually is this gradual change in the brain. Delirium, just like dementia though, affects things like your attention, your memory, your cognition, and your consciousness level. But this change will usually happen over the course of hours or days, as opposed to years with dementia. Patients with delirium often have this decreased awareness of their environment and become very confused. So if you're having a conversation with them, they might not be able to stay focused on one particular topic, and they might wander or be easily distracted by something else. Or they may simply not respond to the environment at all. They may also have this poor ability to remember things, especially with respect to recent events. And finally, in some cases, they might have hallucinations or extreme emotions like fear, anxiety, anger, and depression. Many of these symptoms are similar to symptoms of dementia. However, with delirium, these symptoms can fluctuate throughout the day. So there might be periods where no symptoms are present and everything is normal, and then there might be sudden periods where some or all of the symptoms appear. And with that said, delirium and dementia are different disorders entirely. But because of the similarities in their symptoms, it can sometimes be really hard for doctors to distinguish between delirium and dementia, especially because delirium can even happen alongside dementia. So in order to tell the difference, there are a couple of important things that physicians will look for. They'll first try to figure out when the onset was, that is, when the change in mental state happened. Delirium is a relatively sudden change in cognition that seemingly can go from no symptoms at all to major symptoms very quickly, where dementia starts with these minor symptoms that usually get worse gradually over long periods of time. And they might also test the patient's attention. Staying focused and maintaining attention is often seriously limited with delirium, where patients in the early stages of dementia are generally pretty alert. And finally, and probably most importantly, they'll try to figure out if the symptoms fluctuate. Symptoms of delirium can fluctuate significantly, coming and going throughout the day. If you plotted them on a graph, it might look something like this, where symptoms come and go relatively frequently. And patients with dementia, though, will have this pretty constant level of memory and thinking skills over time. It might get worse gradually, but you don't see this huge fluctuation like with delirium. Cases of delirium are usually caused by this disruption in the normal sending and receiving of brain signals, which more often than not is from a lack of oxygen or some other substance that the brain's used to receiving. And because of this, and unlike dementia, delirium is typically temporary and reversible, which is a major distinction. It's not necessarily permanent like dementia is. And drugs are a very common cause of delirium, especially the ones that tend to cause a change in the way the brain functions, right? Drugs like anticholinergics, psychoactive drugs, and opioids are all culprits. But also it can be caused by the withdrawal from certain drugs and from alcohol. Alcoholics may develop delirium if they suddenly quit drinking alcohol after drinking for a long time, and this is sometimes called delirium tremens. Another major cause are stressful situations. Stressful situations alone might be enough to trigger delirium, especially when they're paired with drugs. For example, delirium is common after a surgery, which is 1, usually a very stressful ordeal, and 2, usually accompanied by drugs or sedatives during the surgery and likely pain medications after the surgery. Also, other physiologic conditions that may cause delirium are things like dehydration and electrolyte imbalances, and infections like urinary tract infections, pneumonia, skin infections, and abdominal infections. Delirium is significantly more common in the older population, although it's unknown as to why, though there are a couple theories. One is that the neurotransmitter acetylcholine is reduced when the body is stressed, like with drugs or just stressful situations. Since the amount of acetylcholine the brain makes tends to decrease as we age, older people are more susceptible to further drops in acetylcholine levels during stressful situations. Secondly, as we age, the body becomes less able to filter toxins in the blood and prevent them from entering the brain. So as you age, it may be that more toxins are allowed to accumulate in the brain, therefore making delirium more likely. Since delirium is, in fact, reversible, it's super important to have properly treated. But the treatment given will depend on the underlying cause, right? For example, if dehydration is suspected, administering fluids and electrolytes will help correct the problem. Or, alternatively, if drugs are involved, removal of the drugs may help resolve the delirium. Oftentimes, it's important to provide supportive care for the patient if they're susceptible to cases of delirium, or during their recovery from delirium. Keeping patients calm and oriented with their surroundings is very important. The less stressful, the better. Things that are helpful are things like regular verbal reminders of their location and what's going on, involvement of family members, use of relaxation techniques, and making sure that they're given proper nutrients and fluids.
Okay, that concludes the video and our presentation. I'm going to take you to our Works Cited page. And that concludes our presentation for today. Thank you for watching.